Hello, and welcome, and thank you for joining us for today's session on frequently asked questions on autologous stem cell transplant. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Amrita Krishnan and nurse practitioner Cherry Lou Rudge from City of Hope Medical Center in Irvine, California, and their patient, Mr. Todd Kennedy from Cota de Casa, California. This live stream follows a recent webinar on this topic that can be viewed on our Educational Resource Hub page on the MMRF's website. So here our panel will cover some questions from patients that were not covered during the webinar. So let's get started. Welcome to everyone, and thank you for being here with me today. So Dr. Krishnan, could you give us just a high-level overview of autologous stem cell transplant, where it fits into the typical myeloma treatment plan, and what the current consensus is on earlier transplant versus later transplant, and what other issues are still being debated about this procedure?
Thanks, Mary. I think you said the keyword consensus, because there really is not consensus anymore, but I think it still remains a mainstay of the upfront therapy for myeloma. And basically, it's really a way to give high-dose chemotherapy that targets myeloma. So the magic is not really in the transplant, it's more in just the ability to deliver chemotherapy that will then basically hopefully kill all the myeloma in the body, but also kill all the other cells in the bone marrow. And the transplant comes about because you're trying to rescue the bone marrow with stem cells that you've collected ahead of time. To your point about the early versus delayed question, I'm sure you in your prior seminars went over the determination trial, which looked at this concept of early transplant after 3 drugs, so RVD, compared to a group of patients who elected to delay transplant and continue RVD for a total of 8 cycles. So, the challenge is, as I said, there's no consensus because the field moves so quickly before we have answers. And some of the challenges are, number one, we have new trials that have read out, such as the Perseus trial and the Griffin trial, that suggests that we no longer actually use just 3 drugs anymore for induction, we use 4. The Perseus and Griffin trial were in the setting of also transplant. So the equation becomes a little bit more complicated. I think the general agreement is transplant upfront still offers the longest lengths of remission. But the data does not suggest any longer that it increases survival because of some of the treatments available at first relapse.
Yeah, so there's been such a lot of discussion about that, the results of that study since it came out. And we're still trying to figure out exactly what the results mean. But I think that what the data shows is that certainly remission is longer if you do the transplant up front, but there really doesn't seem to be such a difference in overall survival depending on, and it doesn't seem to depend where you do the transplant. So that's, I guess, where some of this, stuff comes in. So during the webinar, there were a few patients who asked whether there were differences between stem cells collected from bone marrow versus stem cells that are collected from peripheral blood. So Dr. Krishnan, can you talk about that? And is there a difference in outcome based on the source of stem cells?
There is, but not in this setting. But, many, many years ago, 20 years ago, we only used bone marrow for everyone. That was just because that was the only source of stem cells we had. Stem cells taken from the bone marrow tend to be more immature, so the period of low blood counts is longer. It's about 20 days versus about 10 to 12 with stem cells from the bloodstream. So technically, you're more at risk of infection during that longer period. In the setting where you use stem cells from a donor, that's really where you see the big differences between bone marrow and peripheral blood stem cells, without getting into the weeds, because it's not really relevant to myeloma. Just suffice it to say the biggest difference is just the length of time for those cells to mature.
Okay. So Cherry Lou, thank you for being with us today, and it's really nice to meet you today. So how long are patients typically in the hospital before, and then during, and then after a transplant? And are there limitations to what patients can do after they have a transplant?
First of all, thank you for having me here today, and great question. I think discretion is important with complex and lengthy answer from my side, but I'm wondering if this question is coming from concerns that transplant will involve long periods of time where you have to be at the hospital around the clock. So before I get into that detail, I think it may relieve some of you to know that this process, long though it may be, is done almost entirely on an outpatient basis, where you receive your treatment during the day and leave in the afternoon or evenings. Hopefully that is encouraging to hear. Now, to get started, I'd like to define some of the terms and clarify how I am interpreting this question as well, so that everyone can be on the same page when they hear me say before, during, and after. What do I mean when I say day hospital as well, right? Day hospital is a facility where patients will receive their transplant and medical monitoring for about 2 weeks. And it's not a place where a patient will stay or be stuck for 2 weeks. You will be there during the day and will return to your home or hotel, depending on the requirements of the facility where you are getting your care. So I would say during the transplant, it's about 2 weeks that you will come into the day hospital. But prior or before, it's mostly outpatient. And the follow-up question regarding if there are any limitations that they do after the transplant. There are general guidelines to follow after their transplant. And yes, there are limitations. My top 3 would be focusing in on number 1, preventing infection, such as avoiding crowded places, and also avoid gardening given risk of fungal infection, and keeping your house clean. Number 2, try not to overexert yourself physically. It is normal to feel tired, and after the transplant from the chemo and the low blood counts as well, but maintaining a little bit of physical activity is important for a lot of things. So we generally encourage mild exercise such as walking. And the third part is food limitations, but patients will receive a whole list of foods to stay away from while you're going through this process. And we generally ask the patient to avoid eating out or eating raw food. So for my sushi lovers over there, you'll need to be peace with not having it for some time.
Yeah, I guess that makes sense, right? So,
thank you.
So Dr. Krishnan, what impact does having high-risk myeloma with high-risk genetics have on transplant? Is the treatment approach any different with a high-risk patient than with a standard risk patient? And are outcomes different in those 2 patient populations?
So in the high-risk setting, it's not so much the actual transplant, but it's everything you do before and after where there are differences. And we definitely tend to use 4 drugs before. And often maintenance therapy is with at least 2, maybe even 3 drugs if you count the dexamethasone as well. Or even sometimes 4 then if you say we use proteasome inhibitors, immunomodulatory drugs, and CD38 antibodies, and we tend to not discontinue them, which I think is the biggest difference. So with sort of high-risk myeloma, it's sort of we just don't take our foot off the gas. We just to try and really keep people in remission.
Mm-hmm. Okay, so Todd, thanks for being here with us today. We appreciate your perspective as a patient. So can you tell us a little bit about your transplant experience, including, from induction right through to maintenance? I know it's a long story, but so go ahead.
Thanks, Mary. It's really great to be here, especially with you, with Cherry and Amrita. I feel like you're all part of my care team, so I'm really grateful to share this time. And let me start with just kind of a standard disclaimer, because what I'm going to share is just one person's experience. Your results and your decisions may vary, but I'm hoping there's some value in sharing that story. So I was diagnosed with myeloma unexpectedly on the day after Christmas in 2017. And like almost everybody, I was just completely overwhelmed because it's so complex and so much to learn. But one of the things I picked up very soon, much of it was from reading of the MMRF, was the importance of getting a consultant, a myeloma expert on your team. And so I was really thrilled early on to get Dr. Krishnan and Cherry on my team. And during that first meeting, Dr. Krishnan confirmed my diagnosis. We discussed the pros and cons of various treatment options, including transplant. And I told her that my goal was to try and get the deepest possible remission possible. And it was kind of rough, about the process. And we talked through, my age, my health, the latest research, my staging, my risk level, which was standard. And I don't have an M spike. I'm Kappa light chain only. And after all that discussion, we decided together, it was a shared decision, that transplant and auto transplant was right for me. So before the transplant, my frontline therapy, my induction, was quadruplet therapy. Dr. Krishnan talked about some of the more recent research too, but she did that for me in 2018, which I'm very grateful for. So that was RVD, Revlimid, Velcade, and Dex with daratumumab. We did that for 4 cycles, and my kappa light chains went from super high of 173 down to 1.94, which was normal. And that was just before we started the transplant. So that quad therapy was a really effective induction for me. So then we proceeded to the collection, and it took about a few hours over 3 days. And really, it was more boring than painful. There's no pain involved in the harvest process. And then just a short while after that, we started the transplant, which, as Cherry mentioned, I did mine as an outpatient. So I stayed at a little studio on the City of Hope campus and made those daily trips into the clinic. Worked out really great. On the day I got my melphalan, that high-dose chemo that Dr. Krishnan mentioned, I will tell you my expectation was that since this is high-dose chemotherapy, I thought instantly my hair was going to fly off my head and I was going to start throwing up like nonstop. But in my experience, it really was. I was bald by choice already, by the way, just so you know. And it wasn't really as bad as the kind of worst case scenario that I had put in my head. It was kind of nice to have one of these expectations that was exceeded, because there was the significant fatigue for sure that Cherry talked about, but I never had any nausea. I never had any vomiting, very few GI events. And I don't want to minimize the fact that those can happen, because most people do. But I think I might have been a little bit lucky, but I think it was probably more than luck. It was all the supportive meds and the really careful monitoring that I got from my care team, because they're doing transplant all the time. They know how to keep that quality of life as good as possible during the process. So then I got my stem cells on June 28th. And it's such a climactic moment. You think, oh my gosh, here they come. The stem cells are back. But it was kind of not a big deal. You just get this bag of stem cells infused over a short period. And the process
That's so funny.
was not a big deal, but it was a huge deal as far as kind of sometimes celebrate the day they get their stem cells as their new birthday.
Right.
So for us, June 28th is my stem cell birthday. And I'll be celebrating my 6th stem cell birthday next month. So I'm looking forward to that.
Amazing.
And then it's just waiting, over the 2 weeks after that. We just spent a lot of time just resting and reading and streaming and monitoring vitals and watching for the side effects and waiting for those stem cells to really engraft. And I remember clearly, though, each morning I'd go into the day hospital, we'd do the blood work, and I'd be waiting for those labs. And it was really cool around day 8, day 9, when you could start seeing the white blood cells and the red blood cells and the platelets coming back. It's like, yeah, go, you're just like each day they nudge up just a little bit more. And it was just kind of evidence that what we were going through was really working, and that these stem cells were really kind of happy in their new refreshed bone marrow. And I went home 16 days after I started the process, and I was back to work remotely within 1 month. And then I was back on airplanes traveling for essential business meetings within 3 months. Now that was pre-COVID, and we weren't, as conscientious about maybe some of the infection risk of travel and meetings and stuff like that. But I was able to do it. And it was pretty quick. And that was maybe easier than most. I think some people, they say 3 to 6 months recovery, maybe a little longer than that. But now I'm on maintenance and enjoyed this deep remission and a really full life for over 6 years, and couldn't be more grateful to, Dr. Krishnan, Cherry, the MMRF, and all the others that have played such an integral role in getting me to this point in time. And transplant's been an important part of it.
That's great. That's an excellent success story. Really good. So did you then have to get all of your vaccines over again? And when did that sort of take place in the process?
As I recall, I think we started that process around 6 months post-discharge.
Mm-hmm.
And yes, that was a bit of a surprise. I mean, I read it, but I think most people, they have to appreciate not only that has to be done, but in the interim, that you have very little protection against things that you might have otherwise not been at risk for. I remember back in 2018 where I was traveling, I was getting up to the Pacific Northwest and they were having measles outbreaks, random measles outbreaks. And I'm like, time out, people. I don't have any prevention, have any protection against that. I'm a little baby here as far as the vaccines.
Yeah. Wow.
So yeah, under control now.
That's a great story though. Good. Really good. Let's see. So Cherry, we had a few patients who were asking about Medicare coverage for a transplant and whether they would pay to harvest and store stem cells for later in case people wanted to do a late transplant versus an early transplant. So what can you tell patients about that process and whether or not it's covered?
Actually, for this question, I don't take the lead on this question, as we at City of Hope, we have financial counselors who specialize in navigating the insurance process.
Okay. I have heard that they do cover at least one. They cover one transplant, right? But they won't do a second one. Is that true?
I mean, I think it's very state dependent. Medicare, as I've learned, is different in each, and that's why it's hard to be really global. I forgot the name of the contract. It's but it is Meridian, and it's dependent, as I said. Even might be institution, but definitely state dependent.
Yeah. Okay. So then patients really should be asking the financial counselors at their center what the procedure is for their particular center or state and find that information out. So
correct.
Excellent. Okay.
As a patient advocate, I do get that question. I do get that question a lot, though. Is it possible to harvest and store? Maybe I'll do the transplant down the road, or maybe I need the stem cells for maybe a improvement in blood counts after CAR-T or something like that. So I know it's a big question that's coming up. So I think asking your center, is it an option, is a great question.
Yeah, just so you know for future reference, right? So
yeah.
So there were several patients during the webinar who had comorbidities or were undergoing treatments for other conditions, and they were wondering whether transplant was still appropriate for them. So Dr. Krishnan, can you tell us what comorbidities might prevent a patient from being suitable for transplant? For example, those undergoing treatment for other malignancies, are they still a candidate for a transplant, or would you have to wait?
And that's a tough one. It really depends on what the other malignancy is. Are you needing other chemo for that other malignancy, for example? We've certainly transplanted patients who've had a history of breast cancer, including those who've had chemo, but obviously it's usually several years out from that history. Other cancers, again, if it's superficial cancer, well controlled or treated, skin cancers that are excised, even prostate cancer that's just an observation, for example, all of those are not, things that will be absolute contraindication to going ahead with the transplant. And then in terms of other issues, it's really heart and lung function. And it's not so much the chemo, but it's being able to, the fact that if you get a complication from, especially infectious complications, you have enough reserve really to handle that. So I'd say the things that would say an absolute no-go would be people, for example, have uncontrolled heart failure or, very, very poor respiratory status needing oxygen, for example.
So that would sort of go with the frailty part of it, right? So yeah, that makes sense. Okay, so Cherry Lou, we talked a little bit with Todd about vaccination. So when patients ask you about being vaccinated after their transplant, like what is your advice to them? How does that go?
I mean, I know Mr. Kennedy had mentioned that he got revaccinated after 6 months, which is correct. So, Mr. Todd, great. So, following your stem cell transplant, your antibodies against vaccine-preventable diseases, meaning everything that you've been vaccinated against throughout your life, will decrease. So, in other words, you lose your immunity to this disease. The good news is that you can be revaccinated and get that immunity back. At City of Hope, we recommend starting the revaccination process about 6 months after your transplant. The one early exception is the COVID vaccine, which you can get after 3 months. For the vaccines that uses live virus to generate your immunity, like measles, mumps, or rubella, we recommend waiting at least 2 years after your transplant. However, live virus vaccines are not recommended for individuals who are more permanently immunocompromised, for example, on long-term immune suppressing drugs.
Mhm. So thanks, Cherry. That's like some great information. So we had one patient from the webinar who tested MRD negative after induction therapy, and they asked whether they should wait for their transplant, given that they had such a deep response to induction therapy. So this goes back to what we were talking about with the determination trial again. So Dr. Krishnan, where is the state of clinical practice on that issue? And is that like sort of just a decision that patients would make with their doctor?
Exactly. It's still very individualized because you still need to look at for example, what is the risk status of that patient? How old is that patient? But certainly one could say becoming MRD negative early is a good sign, but really the more important thing is staying MRD negative. And that's where, that's unfortunately you can't tell that ahead of time.
Nope.
So there is still a little bit of caveats with all of this in regards to using one time point to make all your clinical decision making.
Mm-hmm. Yeah, sustained MRD seems to be the way to go, I think, with most of these things. So, okay, so speaking of that, Todd, you mentioned expecting a very deep response or maybe even being MRD negative after your transplant and then being slightly disappointed that you weren't completely negative. So what have you learned since then? And what can you tell the patients who are listening to our broadcast about that particular issue?
Well, I'm an optimist and I'm a type A person. So when I heard MRD negativity was something to strive towards, I'm like, yes, I'm going to do that. I'm going to do that, And I think I almost had an unrealistic expectation. I think throughout the journey, having realistic expectations is really very important. And somehow I expected that I would be MRD negative like 30 days after transplant. And it wasn't something that Dr. Krishnan or Cherry or anybody told me. It was just, it got into my head and I set this kind of perhaps an unrealistic expectation. What I did not know, because when I had my first test, my MRD was at 213, certainly not 0.
Mm-hmm.
And so I was disappointed. But what I didn't know is that that response can deepen over time. And somehow I missed that. And I think that's helpful to know because over the next couple of months with some consolidation therapy and then ongoing maintenance, the transplant wasn't the end of the story. My response continued to deepen. So, and to be honest, I've never been MRD negative at the 10 to the -6 level. I've been 10 to the -5 on a number of different points. And like Dr. Krishnan said, we're looking at sustained MRD negativity as something that will be helpful, but it doesn't really tell the whole story. It's just one part of this puzzle around coming up with the optimal treatment plan for me that has continued to evolve over time. But I think the expectations part is so important, trying to do your best to understand what's a reasonable expectation, and I missed it a little bit on the expectation regarding what my response would be. And it can deepen. You see that all the time, right? Dr. Krishnan and Cherry and Mary, that it can improve.
Absolutely. Yep.
Yeah. I mean, I think that's a big part of maintenance is even just in the old days, maintenance, a third of people's response would improve.
Mm-hmm.
And so Todd, you're still on maintenance after your stem cell. Is that where you are now?
you broke up there a little bit, but I think your question was regarding, am I still on maintenance?
Yeah.
Okay, yeah. So, yeah, my maintenance, it's evolved over time from a few cycles of post-transplant consolidation with Dara-Pomdex and then Dara alone for a while. And now my maintenance is Dara Fast Pro with venetoclax because I have the 1114 translocation. And that's worked really well for me. And like I said, not MRD negative, but very low and stable over many, many years. And that's just what's worked for me. I think, again, the important point is that's a story of one, and that this is a very personal disease, and working with an expert like Dr. Krishnan or so many others, helps you figure out what is the right duration and the right strategy overall to maintain that deep response. That's worked for me, but I have many, many friends that get their different ways.
That's right. It's myeloma is never one size fits all, right? It's different in every patient. So speaking of maintenance therapy, we had a number of patients on the webinar, Cherry, who were thinking about maintenance and asking about it. So what do you do for patients who struggle with Revlimid, which is arguably the most common maintenance drug? Are there alternatives to taking Revlimid?
Thank you so much for this question. I know this is a very kind of like questions that get asked a lot of times. So Revlimid is a chemotherapy pill that most of our patients take as part of their treatment for multiple myeloma. Like all other chemotherapy medications, it could cause a number of side effects and that we need to watch out for, such as skin rash and blood clots. For me, patient education is super important first step in helping patients who may struggle with this medication so that they're not caught off guard by the experience of these side effects. For some side effects, an ounce of prevention is worth a pound of cure, right? So we will recommend things like aspirin to prevent blood clots. When side effects cannot be prevented and become intolerable, we have a few initial options. For example, if a patient develops a skin rash from Revlimid, we can either hold the medicine until the rash clears up, then restart the Revlimid. Or we can also use an over-the-counter antihistamine to take along with the Revlimid. If we find that these mitigation measures are not adequately managing side effects, or if Revlimid is beginning to cause other medical issues, then I typically will defer to the expertise of Dr. Krishnan in choosing an alternative maintenance medication.
Okay. Yeah, that makes sense. And you can always dose reduce sometimes too,
Correct.
right? Is sometimes helpful.
Correct. Absolutely.
Okay. So there's been a lot of talk lately about secondary malignancies caused either by transplant or by maintenance therapies, or even some of the newer therapies like CAR T. So what do you tell patients about that, Dr. Krishnan, and the chances of that happening to them?
I mean, the risk is certainly real. It's about 3 to 5% after stem cell transplant. The risk after CAR T is a little bit more undefined. Some studies suggest up to 10%, but those are a very different group of patients. Patients after the CAR T in those trials had 6 prior lines of treatment. So it was, what was the causality really is still, the issue. I think part of what we're trying to do is better understand who is at risk for developing a second malignancy, even not just based on the number of treatments they've had, but, looking at things such as something called CHIPS, a clonal hematopoiesis. It's not a test we routinely do pre-transplant, but, that may be something that we ultimately doing, or more genetic sequencing as well. For there are certain, again, genetic findings that are sort of more commonly associated with some second malignancies like myelodysplasia or leukemia. The other second malignancies, the sense is, obviously skin cancer is very common. We recommend people do whatever the usual measures to try to prevent that as much as they can. And also recommend people obviously keep up with their other routine health screening. So trying to do everything we can to mitigate that risk is important as well.
Mm-hmm. Mm-hmm.
So Cherry can tell you, we've found at least 2 cases of colon cancer and just PET scans that we've done for myeloma.
Really? Wow.
Totally agree. Yes.
Boy, that's something. So, Todd, we already talked a little bit about what maintenance regimens that you've been on. So, how has that experience been for you on these regimens for so many years?
Really, it's been just like been able to really live my life, to be honest.
Mm-hmm.
I mean, again, probably the trickiest part was that very short downtime during the transplant, maybe just 2-3 months really of the transplant, and then progressing over to the maintenance. And with the daratumumab, that's now on a once monthly basis, just coming into the center. And I just love seeing the people around there anyway. So that's not a burden on my time. And then the other maintenance is oral. I take venetoclax, many other Revlimid, and I managed to tolerate all of those treatments very well. So that hasn't slowed me or my family down at all. And, we have a good quality of life, and we just continue to keep on trucking on and making new family memories and celebrating more and more milestones along the way. So I think the maintenance for me has been a really important part of keeping that deep, durable remission. And the nice part is that it's been without sacrificing quality of life.
Yeah. So that is good. It's very good. So, Dr. Krishnan, what's the consensus on subsequent transplants after relapse? So, second transplant or even third transplant. I mean, back in the old days, transplant was really basically the only therapy that myeloma patients had to keep themselves alive. So people were transplanted kind of over and over at some points. But now there's many different therapies that help a lot more. So are having these like multiple transplants recommended, especially because these days we have so many other drugs that people can turn to?
I think some of it depends on where you are. There are certain countries where you don't have access to that plethora of other options, specifically really CAR-T, which is now approved as first relapse and second relapse, depending on which product. But other countries, they don't have that. They don't even have CAR-T approved in advanced disease. So certainly second transplant remains a viable option, especially for people who've had a very long first remission, 4 or 5 years. Certainly we have done it on patients. But I would say it's not become kind of the mainstay that it was any longer, just because, again, of these other options. But it all depends on the nature of relapse of a patient. Someone who relapses very early after a transplant, we're definitely not going to recommend second transplant at that point. But people who have very high risk disease, again, that's maybe where CAR-T would have a setting more over transplant at that first relapse.
Okay, so we just sort of run through this whole thing already. So there's been a lot of comments. Holy cow. Just looking to see if we can. Okay, this is going to be stuff about a trial. Okay, so we have one patient here who was talking about a transplant and saying that you need to have a caregiver. If you're going to have an outpatient transplant, you need a caregiver, like a 24-hour-a-day caregiver, right? And if you have no one, then you can stay in the hospital. This particular person was in the hospital for 17 days. And the important part was to wait until the white blood cell count comes back up so that you can then be more protected from infection.
I think that's very center dependent again, Mary, in terms of, we, for example, have paid caregivers for people. I don't want to, in very special circumstances, whether that's insurance, it's again, very special because it depends on each patient's insurance and what they will cover.
Right.
But the only patients we do inpatient really are people who are on dialysis. But other centers are very different. Some of them don't even have outpatient, right? So in fact, everyone's going inpatient. So
Mhm.
I think it's hard to generalize in that setting.
Mhm. Agree. So here there's someone who said that both their grandmother and their mother died of multiple myeloma, and asking if there's any genetic factors that we know of that can predispose patients, in families to multiple myeloma. And many patients ask that question. So what is your comment on that, Dr. Krishnan?
So there is a slightly higher incidence. It's about 1.5 times higher in first degree relatives of people with myeloma. The issue is there's something called absolute risk, right? If something happens in 1 in 100,000 people, if you double the risk, it's 2 in 100,000 people.
Exactly. Mhm.
So you have to take that in context of
Mhm.
really what is the ultimate risk for you. But yes, there is a slightly higher risk.
Yeah. Okay. So, and can you talk a little bit? I mean, we did touch on this a little bit, but on eligibility for transplant and what that really hinges on. Like many people think it's more of an age thing, but it really isn't. It's really more, fit patients versus frail patients, right? For eligibility for transplant. So, can you talk a little bit about that?
I think you kind of covered it, Mary. We do have a set, amount of testing.
Mhm.
Again, it's really more to be able to tolerate any complications of the transplant.
Mhm.
I think the one thing I do want to touch upon is you don't have to have good kidney function, because obviously a myeloma can be a disease that affects the kidneys. And so we, as I said, even transplant people who are on dialysis.
Mhm. Great. Okay, so I'm going to move on then to our final thoughts. So Todd, I'm going to start with you. So what are some tips and pointers you can give to myeloma patients who are planning to have a transplant or maybe have just gone through transplant?
Yeah, and I'm looking at the comments too, and there are a number of people that I see some that, somebody just came out of transplant in their recliner at home, and some
Yep.
looking about going into it. I think just the one big tip is have hope, because if you're new in this journey, I think hope is something that's entirely justified. There's so many reasons for hope. We've talked about people that are considering transplant. We talked just now about eligibility. And I know that there are some then that are maybe going, hey, transplant sounds like it's a pretty good strategy. There's good evidence, but they're not eligible. And I would just say to those people that just know that there are reasons for them to be hopeful as well, because there's a lot of evidence regarding ways that you can come up with a good strategy for somebody that's not transplant eligible. I would say a thought on there are some patients that are eligible, but for a variety of reasons have decided to opt out of transplant. And I would just say on that one that just know that there is no judgment on what your decision is. It's a very personal decision on whether you do or don't have a transplant, whether you have one early or late. But I would just say that my suggestion is to recognize that this is a very important decision not to be taken lightly, because there's evidence that this is a very powerful treatment option. So I would say consult with your expert to help you process the risks and the benefits. And again, if you go on Facebook and look at some of the groups, you hear a lot of stories about people that had really rough experiences. People like me are not posting on Facebook about how their life is so great because we're out living our life. So, talking to your expert about, your personal situation and giving that decision around transplant a very careful, thoughtful consideration is important. Like Dr. Krishnan, she mentioned Perseus and Griffin, and, those were helpful in helping us figure out, quad therapy as a potential new standard of care, but those were all done still with transplant.
Oh, sure.
So those kind of remissions came in that whole thing. So, and if you decide to have a transplant, just a couple tips and pearls that I picked up and just in personally and talking to some other patients along the road, I would just say these are practical ones. It's just a time for, resting and healing, and just try and make yourself as comfortable as possible, not only for the patient, but we mentioned so many are outpatient now too. So trying to make it comfortable for the care partner, because they're going to be busy during this process. And if you're staying away from the hospital as an outpatient, if you're not at your own home, just bring things that make you comfortable, like a favorite blanket, comfortable pajamas or slippers, maybe pictures of family, friends, and pets, and make it as comfortable as possible. We say bring some favorite snacks, that are healthy ones that are on the approved list from your prep class, and bring some cool stuff for, snacks maybe for the nurses and things. We oftentimes tend to like show our appreciation at the end. I like to show them my appreciation at the beginning. Sometimes we call them nurse bribes, because if you show,
I'm all in for bribery.
if you show them, if you show them love early on, I promise you they will show you love back early and often as well. So bring soft toilet paper, because it always seems like toilet paper at a center is harder than you would like, and you might need soft toilet paper. I'll leave it at that.
Very important.
Yes. I say take pictures and maybe even journal, because you're going to be looking back at this experience years from now. And I wish I had more pictures. I have a great picture of the June 28th when I got my stem cells with decorations and things like that. But I would say, even if you're one that says, oh, I got it, I'm taking a mental picture, ask somebody to take the iPhone or their other phone and take a picture of it, because you'll want to look at that back later. Download some movies, a lot of time for streaming and catching up. Not the most complicated stuff. This is not War and Peace time. This is light fare, because you need to give your brain a break. It's a great time for reading. If you haven't read it, Kathy's book is great. The MMRF founder. If you have, this is a good time to read this book when you're in waiting for your stem cells to come to engraft and things like that. You can pick some really practical, inspiring tips from Kathy, and then I just finally say bring a mindset. Go ahead. Sorry, Mary.
No, I said that her book is full of a lot of useful comments too, for dealing with the healthcare system, et cetera.
It's amazing. Yeah, it is. I think one thing I would say too, that a lot of family and care partners say, what can I do? And I want to do even more. And one thing that we don't talk a lot about is that there is the possibility of a directed donation for blood or platelets. And maybe it's not even a directed donation, just to make a donation of blood or platelets. Your cancer center is always looking for that. And I know a lot of my family, and they said, well, we want to do that. What can we do? And it's just something to talk about that unfortunately we don't talk about enough, I don't think, within the myeloma community. So think about that one. And then the very last one I would say is just bring this mindset of hope and grace, because that transplant is not easy. It really isn't. It's tough. I don't want to minimize it, but you need to remind yourself that this is a really, really powerful step forward. And it's hopefully going to get you back on track with your life. And I think people walk out of it, and the people I talk to, they come out of it with a sense saying, I'm more courageous. I am stronger than I ever knew that I was. And they look back on it, shortly after and then years after, and they say, I'm so glad I did it. Again, it's a personal decision. There's no judgment, but these are just some practical tips from my own experience and from others that I interact with over the years. I hope that's helpful.
Right. It is. I think it is very helpful for patients. So Cherry, thinking about patients who may be on the fence of whether or not they want to do a transplant, or they don't want to do a transplant, or they're afraid to do a transplant. So what advice, when you're talking to patients who are talking to you about this decision, what kind of advice do you give them to help them in this decision?
I mean, I would like to echo what Mr. Kennedy had also, said, and great pointers, Mr. Kennedy. I think this is a tricky question for me as well, but an important one. I think, as Mr. Kennedy had said, this is a personal decision. I don't generally tell what to do. I do not tell what the patient would do. But I think it is important to have multiple conversations with your family and treatment team. I think making the decision after those conversations and after all your questions have been answered will be a great one. And it's not a treatment that you can do on your own. You will need a lot of support from your friends and your family. And I think that the planning and information gathering stages of the process can be helpful to sustain your well-being while you're going through the transplant.
Yeah, that makes perfect sense. So Dr. Krishnan, my final question is for you. So do you see a day when newer therapies like CAR T cell or bispecifics might make transplant unnecessary. And I know that there are ongoing trials at this point that are like already examining this question, certainly for CAR T. So it is being studied, but do you think that will ever actually come to pass? Hard to say.
So, there is the CARTITUDE-6 trial, which is exactly that. People are randomized to either getting a transplant or getting CAR T. Now, having said that, they are offered, the option to collect stem cells. So if they don't get the transplant at the beginning, they still have that down the road. That's actually that trial. People are very divided on, and surprisingly, that they don't necessarily think CAR T will be the better option, which is really quite interesting. So I think ultimately, yes, something is going to replace transplant. It's probably going to be immune therapy based. But the question is, what is that thing? Because obviously, if you're going to replace, you want to also minimize toxicity, and you want to do it with the idea, can you cure myeloma? Really, is what we.
Yeah. So there's been more and more talk of cure as more of these immunotherapies have come online, right? Which I think is a really hopeful thing for patients, right? Because this disease has been pretty intractable for quite some time. So it's great to see that we now have these immunotherapies that people can take even after, 3, 4, 5 lines of therapy and still see a really good response. Right. So it's a very hopeful time, I think, for myeloma patients, because of that. So, okay. So on behalf of the MMRF, I'd like to thank my guests, Dr. Krishnan and Cherry Lou Rudge and Todd Kennedy for joining me today and taking the time to answer my questions and answer patient questions. I'd like to thank everyone who tuned into our broadcast today for taking time out of your day to watch. Finally, I'd like to thank our sponsors, Adaptive, Baxter, Bristol Myers Squibb, Cure, Genentech, Kite, Arcellx, Regeneron, and Sanofi for sponsoring this session. If you have additional questions about what you heard today, please don't hesitate to call our MMRF Patient Navigation Center. Their phone number is 1-888-841-6673, and they can be reached Monday through Friday, 9 o'clock in the morning until 7 o'clock in the evening Eastern Time. Again, thank you for your attention during this time. And again, thank you to my guests. Really appreciate it. We'll catch you next time.
Thanks, Mary. Nice to see you. Thank you, Todd, Cherry. Thank you.